Okay, so Kevin Oeffinger is really the person who worked hard to get here because his flight from Raleigh-Durham, after sitting at the airport for 9 hours, and I got his email last night, was canceled, and there were no flights this morning, so he heroically drove here to be here. So thank you so much, Kevin.
Thanks so much, Patty. It's wonderful to be here. Ron, Ed, everybody. If I start nodding off or fading a little bit, just throw something, not too pointed. Let me set the stage of my topic, which is physical or late effects, if you will, and interventions to reduce the risk of those by three first slides. First one is experience that we had at Sloan Kettering, where I served for 12 years, where we looked at consecutive protocols for Hodgkin lymphoma for patients diagnosed in their adult years. And what you'll note here is that if you look over time, by about 23 years after the cancer diagnosis, the risk of death is exceeded by cardiac disease, second cancers, and other problems over the risk of death from the original cancer. And that's from problems that we've seen. I'll illustrate a little bit more later. Or if we take a different model, let's look at one of the early case success stories, stage 1 testicular seminomas. As we look at the SEER data, we see that this has been a highly curable cancer now for a number of years. And the risk of death, again, from second cancers or cardiovascular disease, some of that related to the exposures and some perhaps related to genetics, is elevated. Or another success story. Now, if we look at the probability of death from breast cancer or other causes among women who are age 50 and older with ER-positive disease, we see that the risk of dying is actually fairly low, and yet the risk of dying from other causes continues to increase. And that's not related to cardiotoxicity in large part. It's because we're aging, and our women are doing well and functioning well after that, and then developing other problems 10, 15, 20 years later. So what I'm going to try to do is go through selected physical issues. I'm going to focus on the two that give us the greatest morbidity and chance for premature mortality apart from the primary cancer. Second or subsequent primary cancers and cardiovascular disease, and then also talk a little bit about the concept of accelerated aging. And I'll briefly mention where we are with interventions, but not nearly as far as we should be, having listened to what Larissa was just saying, the state of where we are 12 years later from the IOM report. I'll talk a little bit about risk-stratified screening, management of comorbidities. I'll tempt you with a little bit of data on interception. And then I really want to draw your attention to where our great evidence is for improving outcomes for our cancer survivors. And that'll be Wendy DeMark-Wanifried's talk on healthy lifestyles, where we have solid evidence. The focus here will be on survivors of adult cancer. Many of you know my work in pediatric cancer survivors. I'm going to focus on adult cancer survivors, but I also want to remind that the pediatric population has been a little bit of our model. And the IOM report for pediatric cancer survivors came out in 2003, and we have a reasonably robust evidence now for developing guidelines for screening for late effects. A sobering statistic, 1 out of every 5 new cancers diagnosed in our country is a second or third or fourth cancer. And the causal pathways are our lifestyle habits, tobacco, obesity, sedentary lifestyles, aging. 2/3 of our cancers in general are patients that are 65 years of age or older. Genetic factors, treatment exposures from the first cancers, and then often many of the above are some interactions between these different factors. So I'm going to walk you through a few examples, and it's purely illustrative to give you a sense of where we are with research on that. So if you look at the cancer group that we see the highest risk for a lifestyle-related second primary cancer, it's our patients that have tobacco-related head and neck cancer. You see, as you go farther out, the risk for a second primary, getting close to the risk of death from their original head and neck cancer. Stated a little differently, this is a wonderful new paper that was published from 12 French registries, a large study, where they're developing a risk prediction model, a 10-year absolute risk, looking at second primary cancer. So if you look at the patients with Hodgkin lymphoma, with head and neck cancer, age 50 to 64 years of age, you look at their 10-year cumulative risk of having any type of second primary, it's almost 1 in 5 by 10 years out, and substantially higher than what we see in the general population. we go back to the SEER data and we look at what are those second primaries we see in this population, well, we expect to see some head and neck second cancers or esophageal, but also not surprising with the tobacco exposures, an elevated risk of lung cancer, a group that we can actually screen for if you can think of it as a ultra high risk lung cancer population. I mentioned aging as the second example. We see this a lot now in our studies. After you've had your first cancer, you're actually more likely to have a second cancer than somebody to have a first cancer. Not surprising. There's something along those pathways. Again, any of those different causal pathways I talked about. So if you look at the hazard ratios for females or males for age, they have an elevated risk of having a second primary cancer, and that increases with age, especially among men. If I go a little bit more granular on that and I look at women who have had a first breast cancer or first colorectal cancer, and I look at their 10-year cumulative risk, you see that increased risk and increases with age again, higher than general population, a little higher with the colorectal with your first cancer because the cumulative risk of breast cancer. Or in men, a bit higher. We all know that women are more hardy than men. 10-year cumulative risk after your first prostate cancer in men increases up to around 16% for those that are older. And if your first cancer is a colorectal cancer, again, we're seeing some of the genetic influences leading to colorectal cancer, up to 20% 10-year cumulative risk for those that are diagnosed at an older age. The third group, a group that I spend a lot of my time following, are patients that have genetic syndromes that lead to second, third, fourth primary cancers. So those are patients with leukemia or P53 mutation. And if you look, if I can get the arrow here working, around 10 years out, 50% of patients with the P53 mutation have already had a second primary within 10 years. So if your first primary is at age 10, by age 20, you have a 1 in 2 chance of already having had your second primary. Or if I look at another genetic risk group, this is looking at a mismatch repair gene mutation, one of the big subsets of patients with hereditary non-polyposis colorectal cancer. You see again that you have an elevated risk of a variety of different cancers. And here's again some potential targetable, screenable cancers of this group. So if I have somebody that had a colorectal cancer, I can look at their risk of having a extracolonic prostate or endometrial cancer and may alter my screening or surveillance for second cancers in that population. The fourth pathway that I mentioned was treatment exposures. Our model for that are patients that have had Hodgkin lymphoma. This is work from Floor van Leeuwen and the Dutch Hodgkin lymphoma cohort, where they looked at patients that were diagnosed age 15 to 50, largely in their young adult years, over a fairly large time period. And these are different eras of therapy. The 60s into the mid-70s, 80s, and the more contemporary. You see that we really haven't changed risk of second cancers dramatically. And this is the risk in the general population for the same calendar years. And very importantly, these patients not only have second primaries, but often have third primaries, fourth primaries, et cetera. And so how do we screen for those? And I love the question that we had from the young lady earlier. Do our treatment plans, do our survivorship care plans integrate that? And I wholeheartedly agree that we build in cumulative doses so that we base our screening on the cumulative doses of those multiple cancers. What about interaction? I mentioned earlier that we have these separate pathways, but what about when they interact? To me, probably the most illustrative is a nice study that Louis Travis published a number of years ago. This is a case control population-based study looking at Hodgkin lymphoma. Most of these patients diagnosed in their adult years. And what she looked at is the risk of having a second primary cancer, lung cancer in this case, in patients that were smokers or non-smokers, had exposure to alkylating agents or to radiation to the chest area. And so what you see down here at the bottom is the combination of exposures, radiation therapy and alkylators, neither, and some intermediate by non and light smokers and moderate and heavy smokers. And what you see is if you have the non or light smokers, they have a fairly modest increase in risk, not much change with their exposures. But watch what happens when we get to the point of having radiation to the chest, alkylating agents, not even looking by dose, and a smoker. An ultra high risk, an exponential risk, if you will, in this population. So I've spent the first several slides talking a little about second primaries, a big area that we think about who's at risk and what can we do about that. Now I'm going to change and look at cardiovascular risk. Our radiation oncologists have been extremely responsive to late effects, the probably most responsive group, and they have improved upon the radiation fields, going from the old mantle field radiation, looking for Susie. Susie knows this field very well. As many of our patients for Hodgkin's in the 70s and 80s to an involved field, a smaller field, not including the axillary nodes if they're not included in disease, to now just involved nodal, wherever your disease is, including that area and not the widespread area. And so what that's done is decrease the exposure to the breast tissue, so decrease our risk of breast cancer, decrease the risk of lung problems from decreased lung exposures. But regardless of the field, there are the proximal coronary arteries sitting right in the middle of it. The left main, or what we call the widowmaker, if you include that, or the proximal left anterior descending. And even with contemporary fields, this is David Hodgson, radiation oncologist at Princess Margaret, provided these slides for me. Even with our contemporary, we're getting fairly high doses to the proximal coronary arteries in most of our patients because that's where the lymph nodes are being involved in many of our patients with Hodgkin's. So when we look at the data for the risk of significant cardiovascular disease in patients that have had the old mantle or the involved mediastinal field, we see it in both men and women. In fact, this is an area where we don't see a difference in gender for cardiovascular risk. And our young women that are age 35, 45, 50 are just as high as risk as our men that are at the same age. By 20 years after moderate dose radiation to the mediastinal area, 1 in 5 chance of having symptomatic coronary artery disease. By 30 years out, 13% chance of having a myocardial infarction. And perhaps the most startling statistic is if you have an MI after having had mediastinal radiation, you're 3 times more likely to die of it than a man or a woman that had an MI and did not have any radiation to that area. And again, because of the disease to the left main, or what I referred to earlier as the widowmaker. Many of our colleagues, both in US and Canada and Europe and across Asia, have looked at developing dose-response relationships to the radiation and the outcomes that I've just described. And this, again, is the Dutch experience where they're looking at patients that were treated with Hodgkin disease over a fairly long time period by the radiation dose to the mediastinum. So if I take a hypothetical woman that's age 40, and I look at her, if I see her that she was treated with Hodgkin's at age 20, by the time she's age 40, she has a 5.5% chance of having coronary heart disease. Importantly, if I'm seeing her in the office at age 40, and I'm thinking about her in the next 10 years, she actually has an absolute risk of around 10 to 12% of having a serious cardiac event. So again, if I'm thinking about my patient in the office and I pull out my pooled cohort calculator, something that Larissa and I and many of our colleagues in primary care use, that is based upon the Framingham data that allows us to think of somebody's risk in the next 10 years of having a heart attack or a stroke or death from either one of them, and whether or not they might benefit from statin or other interventions. And I look at that individual that I just said, okay, she's 40 years of age, she's white, non-Hispanic, she has a mildly elevated cholesterol, a little bit low HDL, she's normotensive, she's not on any blood pressure medications, she's not diabetic, she's not a smoker. Looks great, right? 40-year-old healthy woman. And if I look at the pooled cohort, it says her risk of having a major cardiac event in the next 10 years is 1 out of 100. So very, very low. And yet I just showed you data that in fact her risk is about 10 to 12% in the next 10 years. And it just reminds us that our risk prediction models that we've used for a variety of different comorbidities in the general population need to be adapted with our treatment exposures to really give meaningful information to our patients. This is simply one of our studies we're working with Denmark in developing risk prediction models for patients who are treated with Hodgkin and non-Hodgkin lymphoma during their adult years. I talked a little bit about the Hodgkin's population for cardiovascular group we know fairly well, but let's focus on our largest population of cancer survivors, breast cancer patients. I mentioned a moment ago that this has been one of our realest success stories. Women are doing very well with early stage ER-positive disease. And yet when we look at women that are in the SEER Medicare ages in their 60s, 70s, and into their 80s, over 50% of them have hypertension or lipid disorders, and a reasonable fraction of them have diabetes. And we know that hypertension, either before the cancer exposure, during cancer therapy, or after cancer therapy, is the single most important predictor of heart failure in breast cancer survivors treated with anthracyclines and trastuzumab. In fact, we've seen that model in multiple cancer groups now, that hypertension is probably the single most important driver of long-term outcomes related to the heart, both in terms of heart failure and coronary artery disease over time. So the caveats from that are most women with breast cancer will not die of the breast cancer. Continuing monitoring management of common comorbidities may be as important for the longevity and quality of life because of the success of our treatment of the breast cancer. And lack of a standardized approach to manage hypertension, diabetes, and lipid disorders is still robbing us of that original cure that we have. Soro Aminian led a group of us through ASCO, working with the American Heart Association, develop prevention and monitoring guidelines for cardiac dysfunction. And in that, one of the questions was, what preventive strategies are effective in minimizing risk during and after the administration of potentially cardiotoxic therapy? And it's modifying these comorbidities, things that we typically have not paid attention to over the years. We've let the blood pressure run a little high, let the blood sugar run a little bit high, not worry too much about the lipids, because after all, we need to focus on the cancer. And 3 or 4 or 5 years later, we still find ourselves in that same pattern. If I go back to our testicular cancer population, but now look at non-seminoma, this is a nice paper recently published by Chunkett Fung and a group where they looked at cardiovascular deaths in this population using SEER data. And what they found is that the risk was really largely during therapy or soon thereafter. And as you look farther and farther out, the risk of cardiac death actually decreased. And very importantly, the older the patient was at the time of treatment, especially if they had multiple comorbidities, the higher the risk was of cardiac death. So I've gone from talking a little bit about second primaries and cardiovascular disease, so I want to spend a couple slides talking about accelerated aging. And it's not simply that we accelerate all the processes of our body. It's often differential. Certain parts of our body age more than others. I absolutely loved Julie's talk earlier about both her personal experience, but also how that informed her career, and thinking about what can we do with avoiding frailty, not only in terms of longevity, but keeping people independent, avoiding them from becoming in a dependent lifestyle. Harvey Cohen, working with a group, used a geriatric assessment called the Deficit Accumulation Index that has a variety of different domains that you see listed here. And you simply take a score from those factors divided by the denominator, the potential deficit score. It's a score anywhere from 0 to 1, the higher the worse, and developed cut points used from the geriatric literature for individuals that are robust or pre-frail or frail. And you can see the distributions here from the Cancer and Aging Research cohort. You see a fairly large group that are still robust, a group that are pre-frail, and a smaller group that are frail. And how does that impact it? Gina Mandelblad did a really nice job working with colleagues in applying that same score to a protocol through CalGB on patients that had breast cancer at an older age. And what you see here, if you look at all-cause mortality or breast cancer mortality, you see a higher risk for women that were frail or pre-frail compared to the robust cohort. We see this also in the pediatric population. This is work that Kiri Ness published a couple of years ago, looking at adult survivors of childhood cancer that were treated at St. Jude's. And when they evaluated them as adults, if they fell into a frail category, the risk of death in the next 10 years was much higher than those patients that were not frail. So predictor prospectively. So we talked about late effects. I used second primaries, I used cardiovascular disease, but there's a whole array. I could have done lung disease, kidney disease, endocrine disease, et cetera, et cetera. And this is an intentionally busy slide just to remind us of the array of late effects that we see depending upon the treatment exposures or other factors that we're dealing with. And if you try to put it all together, this is a nice slide that Melissa Hudson put together a while back that shows a risk of late effects from premorbid condition, the woman that has insulin resistance, and hypertension prior to the onset of her breast cancer. Genetics are important not only for predicting the first cancer, but also for second and third cancers, cardiac outcomes, et cetera. The tumor factors, the treatment factors, knowing the exposures, the doses, et cetera. Events that occurred during treatment, Host factors. I love the question on race and ethnicity. We know too little on the disparities within survivorship. We do know gender. Women are at a higher risk for many of the late effects that we see and second primary cancers than men are for the same treatment exposures. Our health behaviors, how they modify and accelerate this process. And then again, that whole concept of aging. Not only aging of our older patients, but also aging of our younger patients. Where are we with interventions for improved physical well-being? Well, we can apply the average risk screening guidelines, and we do a reasonably good job of this, but not nearly as well as we should. Our patients with second primaries are actually at a higher risk for a new cancer, and yet our rates are no better than what they are in the general population. And we might even give considerations for new screening interval. So the patient that had breast cancer at risk for colorectal cancer, do we do every 10 years colonoscopy or not? In our high-risk groups, we've developed some reasonable consensus-based guidelines for our patients with leishmania and BRCA2, but we have very little data showing what do we do to get patients motivated. This is really scary if you've ever dealt with a patient with leishmania syndrome. The panoply of screening tests that we do is very wide, and how do we make sure that it's the right test at the right time and be able to communicate that with the patient? Our patients that had cancer therapy risk, we have reasonably good guidelines for. And our lifestyle risk, we still focus a little bit too much on the first cancer and not thinking about those second cancers that might be related to the lifestyle risk. For all that I have said, the paucity of data on how do we screen for these with patients that have had adult cancers remains much too low. And that's where we've not made a lot of progress in the last 10 or 15 years. So for example, if we look at cardiovascular, this is a busy slide that shows in Sarominian and the JCO paper for the ASCO guidelines. We know lots of exposures that lead to cardiotoxicity. But if we instead look about what do we do for screening, here's what we came up with. An echocardiogram maybe performed 6 to 12 years after therapy, and we have no idea what to do after that. We do know that we should manage their comorbidities, but we should be further along than we are. What are the barriers to generating evidence? Both NIH, whether NHLBI, National Cancer Institute, et cetera, and our reviewers favor interventions over observation studies. That's natural. I understand it. I get that. But sometimes we simply need good observational studies to be able to really dictate the direction that we go with our interventions. The question we often ask is the intervention going to make a difference? If I intervene early, will I change the outcome? Let me use a quick example of heart failure. American Heart Association a few years ago moved us away from the old New York classification of heart failure and went to stage A through D. A is I'm at risk. B is I have some changes to my heart that I can see technologically, but I'm not having any symptoms. C is I'm having symptoms. And D, it's too late, I have end-stage heart failure. So if we look at mortality broken out by those stages, what you see is if you're stage A at risk or B, just some cardiac, your mortality is not substantially affected. Once you start down the pathway to C and D, you make a significant change. 5-year survival rate for stage C is 75%. When you transition from B to C, it's associated with a 5-fold increased risk of mortality, cardiac-related mortality. So if we look even at ejection fractions, we're trying to find that sweet point, that sweet spot to treat on there. And we look at that patient that has a lower ejection fraction but no symptoms at that point. That's the group that we want to be able to move from finding these structural changes to preventing heart failure. We have a few studies in process here, both on patients that are upfront therapy and patients that are survivors, but still too few data to know, can we actually mitigate this like we do in the general population? Lastly, can we prevent frailty? Now, the LIFE study was a nice study looking at 800 plus sedentary individuals, non-cancer patients, 70 to 89 years of age, using a structured modified intensity physical activity program, fairly simple program. Come in for a few visits and then do it at home versus health education. And what you see in the first slide is that you were able to get patients that are elderly more active, but more importantly, you're able to prevent persistent mobility disabilities in this population. So we need data to see how we can do also in our aging cancer survivors. Can we attack frailty? Can we prevent? Can we keep them functional? Can we keep them independent? Last teaser that I'll have is just precision screening. Second primaries, 1 out of 5 cancers is second primary. The American Association of Cancer Research meeting in this spring here in DC, there were dozens and dozens and dozens of talks about liquid biopsies. Where are we with using cell-free, circulating cell-free DNA or circulating tumor cells for both prognosis and for monitoring for recurrence with that? And at some point, we will be rolling out these tools also in high-risk populations. So thinking of the patient that had a head and neck-related tobacco cancer, for their lung cancer. There are studies that are showing epigenetic marker-based systems with a detection rate in breast cancer that are similar to mammography. What happens when we combine these modalities of both our biomarkers, blood-based, and our imaging biomarkers? And then cancer interception, the ability to identify a mutation, treat that mutation before the patient actually has progressed to cancer. Rather than our old style tamoxifen chemoprevention, can we actually target somebody with an ERB2 mutation that is at risk for HER2 overexpression breast cancer? Can we actually target that with lapatinib and keep the patient from developing breast cancer in the first place? These are all things that will be rolled out and understood and disseminated over the next 5 to 10 years. We need to understand the benefits as well as the potential harms of these approaches. So in summary, what I've tried to do is highlight the fact that survival rates continue to improve, that the incidence and magnitude of the risk of selected long-terms and late effects is robust, but the evidence supporting risk-stratified surveillance and early intervention is still needed. And point again to areas where that we do have great evidence. When our cancer survivors say, what can I do? Wendy is going to tell us exactly what you can do. Thank you so much for your time and attention.